Okay, I think we can start now. So thank you all for joining us today on this webinar about COVID and the London experience, learning from local experience. I'd like to firstly thank the College of Psychiatrists for setting this up. Thanks to Isabel and Jen particularly. Please do tweet if you would wish to tweet. We have 3 speakers with about approximately 10 minutes each and questions at the end, which you can put in the chat room, please. So just by ways of introduction, I want to talk a little bit about our aims of the webinar. The COVID experience really began in London. And we had our big epicenter in April, May. And we thought it'd be good to talk about that and what we have learnt about that. We are the London Division here, which is the largest division in terms of numbers. And so we thought that we probably might have things to share and our learning. We did hope when we were setting up this webinar that it'll be slightly less somber and rather than a bit like, here we go again. But that's what it is, I'm afraid. But why we wanted this webinar, we wanted to learn and share. And I think I was kind of inspired a bit by hearing my colleague Suhana speak before. Now, Suhana is a consultant colleague in the same trust, but hearing her experiences was quite different. And what I know from being the chair of the London Division and hearing across the different trusts is the different practices and experience in each trust, and how we can learn from each other. Now we have a couple of speakers from a number of specialities, but we don't have, unfortunately, people from addictions, learning disability, but everyone has been affected by COVID, personally, professionally, in every way. So I'm sorry if we haven't covered all areas, but there's an opportunity in questions to bring up other issues. For myself, I'm a general adult psychiatrist working in a COVID assessment and testing ward, and it has obviously profoundly affected me professionally and personally. I did have early retirement in the middle of the worst of COVID in London, and I came back after about 16 hours, which I don't know if that's one of the quickest retirements ever. For me, I come from a background as well in global mental health, and it does remind me of working with Ebola in West Africa, where so much was similar. We had the same sorts of conspiracy theories, the same sort of issues about public education. And I would kind of reference or highlight that we are having a global webinar on the 8th of October, where I go from being London to talking about the world. And we also have our COVID newsletter coming out at the end of October, which is dedicated to the subject of COVID. So with that, I will now hand over to my first speaker, who is my colleague, Suhana Ahmed. And Suhana, unfortunately, can't be here today, as quite understandably, she's got some family commitments, and I'm good on her for doing that. But she has thankfully recorded something for us, so we get her experiences as an old age psychiatrist working in the Southwest London Trust. And Suhana is also our finance officer for the London Division. She's been our lead for Start Well and a member of the old age faculty. So with that, I hand over to Suhana's recording, and please remember to write any questions in chat, and we'll, apart from Suhana, because Suhana isn't here to answer. So if I could hand over to the recording of Suhana, please.
Hi there. For those of you that don't know me, I'm Suhana. Firstly, a really big thank you to the London Division for allowing me to do this. I'm really sorry I can't be there presenting live, but hopefully this will do. So I guess a brief introduction. I feel like I work in a very regular setting. I'm an old age inpatient consultant in the southwest of London. It's a 16-bedded ward, and we have a mixture of functional patients and also dementia patients. And I work less than full time, so I tend to work the first half of the week, and Dr B tends to work the second half of the week, who is the other consultant. And in my view, work a very regular job. So, I'm a newish consultant, 3-year CCT. And so I guess this is to look at how COVID affected, those of us on the shop floor, so to speak. So COVID at work, I had preconceptions of COVID. I really didn't think it would hit us hard. I knew that A&E and ITU and places like that would be hard hit. Naively, I never thought it would come to us. And then on that Sunday afternoon, I got the phone call from my ward manager telling us that we had tested 2 positive cases, and there were a couple of potential cases and suspected cases. And I could sense the panic in her voice. So that really was my first meeting with COVID. And I went in that Sunday afternoon, and I was there for about 4 or 5 hours, talking to staff, talking to the ward manager about things. By midweek, we had, I think, about 5 positive patients and 2 suspected. So things had, those first few days, things just escalated exponentially. And what I've done is just thought about really the challenges we faced in those first few weeks. And, there's no pretending that there wasn't a lack of PPE. It was a major issue. And understandably, what that did was raise staff anxiety, and staff were anxious about not having PPE. We had bank staff not wanting to come into work because they were aware we had COVID positive patients. Unfortunately, the consultant that works the other end of the week needed to shield, so wasn't able to be on the ward, which resulted in me increasing hours, which was fine, but impacted on my personal life, as we'll see a bit later on. And visiting was stopped, and obviously that led to anxiety within the patient group, and within the relatives and family as well. So that first month was sort of all fueled on panic and adrenaline and so on. And then we were lucky because we had probably about 2 or 3 weeks where things settled down, and we were COVID free. And then what I refer to as the second wave. So we then had 3 positive and a couple of suspected again. And it was at that point that we decided to revert to an isolation wing. So the male corridor was sort of changed to an isolation wing. So anyone that was COVID positive was placed in that corridor, in that wing, and anyone that was suspected also. There were a number of reasons why we did that, and I'll sort of touch on those in a little while. It meant that we needed to have females and males mixed in there, but I think we all had a discussion, and actually the benefits outweighed the risks. We had the deputy head of nursing come down and literally talk us through it and walk us through what we were supposed to do, but it also had a knock-on effect because it meant a reduction in beds, because certain rooms on that wing were used for sort of donning on and off and other bits. Sort of during that second wave, what was potentially the hardest was isolating patients with dementia. So a lot of our patients have challenging behaviour in the context of dementia, and they wander. So even having a wing where they could walk up and down, isolating them was a major problem. There was an increase in aggression towards staff, and there was an increase in the use of medication, so things like lorazepam, because we were really limited in what we could do, and we had to confine it to that corridor. There was a major issue sort of on the impact that it had on staff, and essentially initially we decided that one staff member would, or two staff members would be assigned to that wing every day, but we just felt that 12 hours on that wing in PPE was too much, so we decided to sort of split it in two, so there would be two sort of 6-hour shifts. Visitors remained off the ward, and also family meetings, which we do a lot of on an old age ward. So we weren't having as much contact with families, and in a way it sort of increased the workload because we were making a lot more telephone calls, updating people via that means. And we touched on end of life care, although we didn't need to use it, but it's something that we started to think about because we started to get pushback from the acute hospitals, understandably. I've put iPad here because actually we made amazing use. We managed to acquire an iPad on the ward, and we made amazing use of FaceTime. So families were able to FaceTime their relatives, and it worked really well. But again, time and resources, because it needed someone setting up those meetings. I guess the other part to this is I'm not just a consultant, I'm also a mum. So Daniel is 7, his school closed, and although it was open for key workers, we decided that we would keep him at home because my husband was working at home. He was incredibly anxious, Daniel, so was really preoccupied about me becoming ill because I was looking after patients with the virus, in his words, and he got very clingy, and my workload increased, so I was working longer hours, I was on my laptop a lot more. So, I underestimated the impact it would have on my relationships. My social support network was very limited. I see my family, my sisters a lot. And obviously, when we went into lockdown, that wasn't possible. And unfortunately, during that time, my dad became very unwell and was admitted to hospital. He wasn't allowed visitors. And I suffered a personal bereavement, which was COVID related. So that sort of added to everything. So, I sort of feel we can all cope with one of these things happening one at a time, but when it all happens together, it just makes things so much more difficult. So what worked on the ward? Things like visibility and structure. So I would make sure I was on the ward every morning at 9. So we had a sort of 15-minute, half an hour handover. Flexibility in terms of tasks and time, so working longer hours. Boundaries, listening to people, advocating for people, and a lot of my nurses on the ward. Being difficult because sometimes the only way that you're heard is by being vocal. And one thing I did do was every few days I would look out for someone that had done something good or well, and I would either tell them in front of their line manager or I would email them and copy in their line manager, and it's amazing how much it raised staff morale. And I was lucky because I had really good interaction with my ACD and my CD. I was lucky in that I had lots of support from the college as well, and I sort of drew on that. What worked at home? Lots of reassurance for my little boy, being honest with him, so him knowing that I was working with sick patients, but actually I'm relatively young, I'd like to think, and healthy, and expressing my emotions. So I would initially try very hard not to show him that I was upset, but I found it easier to start to tell him that I wasn't feeling so good one day, and just accepting that it was an unprecedented time, and lots of hugs. So Dan and I did lots of hugs, and just using the support that was around. What didn't go so well? I guess me realising that I have my limitations. So a lot of the decisions are above my head. There are only so many emails I can reply to. I didn't take time out, so I was working all the time. I was checking email at 10 o'clock at night. I didn't take leave, and I sustained crisis mode, probably for longer than I should. I didn't grieve when I had that bereavement, and I really wasn't doing basics, so things like eating, drinking, and so. Very briefly, post-COVID, so we have seen lots of first presentations, we've seen lots of more severe presentations. A lot of our ward was functional following COVID, so usually we have sort of a 70-30 split, with the majority being dementia. That sort of flipped on its head, so we were seeing a lot more anxiety, psychotic depression. I don't have time to talk about individual cases, but there are some really interesting ones. And these were really difficult to treat people, so a lot of them are still on the ward. So my COVID lessons, leadership counts most in a crisis. Crisis mode is essential, but it's not sustainable. In a crisis, there is always some overlap between your personal life and your professional life and the support networks. Sometimes you have to be the difficult one. There's a balance between being flexible and being boundaried, and it's an opportunity to learn from others. And I mean that sort of professionally and personally, because it sounds weird, but I learned a lot about coping from my little boy. Kindness goes such a long way, and a bit of an obvious one, but lead by example. So at the moment we're COVID free, and I've probably tempted fate. We've got an admission protocol, so everyone should have a negative swab on admission, and if they don't, they are swabbed and isolated until they do. We have weekly swabs. We're still seeing the impact of lockdown. I am now back to my part-time hours, so I get to have more Daniel time. I'm able to use my support networks a lot better, and even though we feel incredibly anxious at COVID returning, which it may well do, we sort of have plans in place now, so we know that we would revert to an isolation wing if we had more than 2 positive patients. We're a lot more up to key in end-of-life care. So leadership for me is stepping up in a crisis, supporting more than just those you directly manage, ruffling feathers if needed, listening to people, accepting that your reaction is going to be different to someone else's, and people react differently in a crisis. A really important one, identifying the positives in a crisis, but voicing them as well. Being kind, paying it forward. So if someone does something nice for you, then do something nice for someone else. And finding your own way of leading. So my way of leading was very different to another consultant's way of leading. But if it's authentic and it's genuine, I think it works even if it is different. This is just a quick plug. So what I did do was a podcast for a fellowship that I'm working on, and it's really just about balancing home life with being a consultant in COVID. I guess what I wanted to do was finish on this quote, and it is amazing what you can accomplish if you do not care who gets the credit. This presentation isn't about me, it's about sort of all the people that were involved in getting us through what we did. I'm so proud of my team, they are incredible. I would never ever have survived without my ward manager. So a big shout out to her, who was a major support to me, but also people outside of my ward. So, you know, my clinical director and ACD were amazing. I had lots of support from the college, so Peter, Jen, Wendy, you know, there are so many people that I can think of, and also sort of my personal support network. So I would never have been able to do any of, you know, we would never have got through it without the whole team. And that's it. So really big thank you for listening. Any questions or feedback, please do not hesitate to email me, even if it's criticism, I can take it. And thank you very much. I hope you all have a lovely day.
Thank you, Suhana, and I'm sure I'll thank you in person as well in due course. So unfortunately, there's no questions for Suhana, so I'll move on to my next speaker, who is Dr. Anil Kumar, who's a consultant psychiatrist in a female inpatient unit, working in the Bethlehem, and has worked in the Maudsley for 15 years before that. And I will hand over to you now, Anil. So please, and We can have questions for Anil, but if you put them in the chat, and we'll take them at the end. Thank you.
Sorry, I'm just trying to share my screen now, so just bear with me for a minute. Can you see my PowerPoint presentation now?
We can, yes. You just need to make it full screen.
Yeah, thank you. Yeah, so as you mentioned, I mean, I'm one of the consultants at the Bethlehem. I was at the Maudsley for 15 years. So, and thank you for the London Division to give me this opportunity to present, to talk about my experience as an inpatient consultant. So I'm just going to talk about the ward in general, and also about the support I got from SLAM as well. So as you know, it was a difficult experience for patients and staff, and it was no different on my ward. You can see that the SMI group suffers from high stress, anxiety, depression, and all that. And the healthcare staff are very prone to post-traumatic stress. And what helps them cope with these stress is actually the support and the management validating their experience. So the frontline health workers had a high risk of anxiety, insomnia, burnout, and all sorts of different psychological problems. So I'm in a rather sort of a peculiar position. I mean, rather privileged position. I'm a sort of full-time clinician among academicians and senior leaders, really. So, which in a way is good for me, really, because I could look after my interest and challenge whatever I could challenge. So, what this period made me more aware is I mean, I thought that the researchers were sort of running around the narrow alleyways they have been running around for the last 20 years when I was a researcher. The middle managers, I didn't know what they were doing. And all the sort of nurses I worked with 20 years ago, where they all disappeared and what they were doing. Suddenly, everything became transparent to me. I mean, then there was this, all the cogs of the wheels, I mean, which, I mean, suddenly became more apparent to me. And all the guidelines people produce, really, you know, sort of being at SLAM, it's good to have all these national leaders there, and it was very useful. I mean, we had more than 15 guidelines, or even more actually. And then there was all these regular meetings, which we call a huddle, between the managers and the clinicians, and focusing on psychological well-being and all that. Managers and junior doctors, there were safety huddles on the ward, support for vulnerable and BME staff, various risk assessments. So I was asked by both my ACD and my CD, Anil, do you have any physical health problems? And they were quite supportive, and they couldn't actually, I mean, they kept asking, are you sure you don't have any physical health problems? Which, yeah, I mean, it was very supportive and very nice of them to ask. I think what I was trying to convey earlier was the health managers have a profound impact on the aftermath of the COVID experience, really. So, we had this inpatient guidance mid-March. So we started having COVID positive patients around mid-March, and then we had this guidance which came out from the SLAM sort of managers, increasing staff absences and isolation led to this, really. So we had to close down wards because of staff shortage. So what it led to, I mean, with the guidance and all that, was to raise the threshold for admission, increase the discharges by lowering the threshold for any patient who had unescorted leave. And somebody was asking earlier about consultant working from home. There were provisions for people to work from home if they did need to, and all patients were reviewed weekly. So the impact of all that was quite a positive experience for me, actually. So, sorry, I forgot to mention the Winston Churchill quote, really, never let a good crisis go waste. The impact was quite positive, because we have our own high incidence of EUPD patients who were quite difficult to place. Suddenly, all the teams sort of, were available for discussion, and we all sort of had our inputs into sort of looking into appropriate placements for these patients, and and it's very pleasing to note that some of them stayed well for a long period of time, and they haven't come back to hospital. So all the long stays were gone within a few months, within a month, I would say. The CMSTs, we could connect with the CMSTs more regularly, work with all the services. Tertiary services were running all these virtual clinics. Of course, there was increased acuity. It was like a mini PICU. But I got some good support from my consultant colleagues. Because of the merger, one of the other consultants came to work with me, much younger and sort of more able to be calmer with positive risk taking and all that. And then I became unwell with COVID for a period. I was away for a couple of weeks, which I'll talk if I get time. So the testing and management, initially it was symptomatic testing. Later, all patients admitted for symptomatic were tested. They were daily monitoring for COVID symptoms. I think 5 or 6, I can't be 100% sure, but I think it is 6 patients were tested positive. All of them, most of them were mild. 2 were taken to general hospital. One of them was not that serious, and the other one had to stay there for a few days, really. So, patients were initially encouraged to self-isolate. There was a period when we had a sort of a informal arrangement where we had a negative and positive corridor, but generally sort of we kept them under observation, those people who wouldn't self-isolate. Female PICU, there was a 3-week period in which all patients were tested positive. I've put the reference for that paper by Dr. Sethi and his colleagues there. So the patient challenges, there was a sort of a significant increase in the morbidity. Across London, there has been a significant increase in the suicide rates and all that. Fortunately, on our ward, we did not have any untoward incidents, but generally, if you look at the community as well, there was an increase in the suicide rates and other sort of physical health, serious physical health complications as well. So, interestingly, we have, quite a few professionals coming to us with first episode psychosis. It was just more than the anxiety and depression and fear of death and all that. People did develop psychotic episodes. We had 3 general nurses and 3 other health professionals. So we had our own challenges. People were struggling to have contact with the family. Not every families were sort of used IT, and so we tried our best to support people to have contact. There were people who were refusing tests and not complying with the isolation. And also the main other issue was we had to stop the unescorted leave. But again, with sort of any changes in the guidelines, national guidelines and all that, we were quick to update that. And by May, compared to many other units, we were able to reinstate some unescorted leave and move people forward if they were well enough to be discharged. So there were challenges with the medication. So the clozapine was a particularly difficult one. But again, we got the psychosis, national psychosis unit, and a lot of input from our pharmacy as well in prescribing clozapine and sort of monitoring the side effects and all that. So the COVID could cause leukopenia, so myocarditis, which are all sort of symptoms which overlap with the clozapine. Same with promethazine, benzodiazepines. So rapid tranq was we had to discuss with pharmacy for some patients who we thought were symptomatic and closely monitor their physical symptoms as well. So loxapine is used in the PICU mostly, not on acute ward. And we put everybody on vitamin D3 supplementation. So there's also this overlap between sort of psychotic symptoms and confusional states in COVID encephalitis, which we suspected for at least one of the patients. So yes, it was quite an interesting and challenging period in regards to patient management as well. I mean, the testing, I had to. I became unwell during the period when testing was not widely available, so I could not get myself tested for COVID. But I did get the antibody test, and I was glad to have the antibodies. So the testing for staff was initially difficult, but it improved as time went. It was quite surprising for me as to how quickly things changed. I mean, initially there were shortages of PPEs and all that, but within a very short period.
Sorry, Dr. Anil, maybe just 1 minute, please.
Yeah, thank you. So within a short period, everything was sorted. I mean, the most sort of amazing thing is the technology. I mean, the advances in technology. Really, sort of, suddenly we are able to do virtual assessments, virtual ward-rounds, better CMST participation, virtual tribunals. I'm a tribunal doctor as well, so and I was examined at the virtual CASC, and we got the virtual RCPsych as well. So very quickly. So yeah, so I think certainly the organizational support helps improve things really, and possibly reduce the post-traumatic stress really. So that is the key message I want to convey really, because all these hurdles, all these sort of informal and formal meetings, and also the transparency helped a lot really. I think when in crisis, I think the helpful nature of a human being and the sort of the resilience, all that comes out a little bit more. And yeah, so as the previous speakers have said, the kindness and the willingness to help. So that makes feel sort of people reassured. Sorry about that, my phone is ringing. So I'll finish there. I mean, sorry, I might have to talk a little bit about my personal experience. I did have, so I thought I was, just like one of my colleagues said, I thought I was custom made to cope with all the social isolation and everything else. I mean, I did got yeah.
Anil, I think it sounds like you've got a telephone call you've got to make. So
no. Yeah, I've just put it off. Yeah, I'll finish there.
So I do have to finish there, but thank you for your very interesting talk, and some of the when we go questions and answers, you might be able to talk a little bit more.
Sure.
So with time a bit pressed, can I move on to Gabrielle? And Gabrielle Pendlebury is a clinical lead for forensic. Sorry, just going on the video again. So Dr. Gabrielle Pendlebury is clinical lead for forensic adolescent services at the Tavistock and Portman NHS Trust and a medical legal consultant for medical protection. And she has put her Twitter handle on the in the chat so that people could contact her. So Gabrielle, over to you, and I will be keeping an eye on the time. So I'll tell you when there's a minute to go. I'm sorry, I've made it like the exams, like the CASC exams. But please carry on.
Oh, thank you so much for inviting me to talk. It's a real privilege to be able to reflect on what my service has done over the past 6 months or so. But also it's quite therapeutic for me in the sense that thinking about, are we going to have a second wave and what might we do differently? So basically, I'm an adolescent psychiatrist and I work in a forensic adolescent team, and I also am half-time medico-legal advisor. And so it's been very interesting to see what's happening nationally, but also what's happening within my team, and use, in a sense, my knowledge from both sides to support colleagues and professionals around the country. So initially, when this all started for the forensic adolescent population, I was really thinking it was going to be you know, akin to what happened in a sense in the Second World War, was thinking there'd be an external threat, that you have all of these young people who perhaps have issues with conduct, and so the survival instinct would kick in, and in a sense there'd be a decrease in issues during the acute phase. But we haven't seen that at all. What we've seen is that the uncertainty, probably with the loss of education, loss of social activities, and also the loneliness, loss of connection with peers, has really triggered lots of anxiety, increased suicidality, mood disorders, and even psychotic breakdowns. And so it's really been a tough time for adolescents. And so I can only be very proud of what my team have achieved, you know, because they've had to really change their whole way of working. So I should say that we're quite a new team, Forensic CAMS. We've only been running for just over 2 years, and there's everyone there. We're quite a small team, and basically it's a new model that was developed to make forensic opinions, forensic issues, so that clinicians could have easier access to that type of opinion. And I feel it's very innovative. We've got an advice line that's 9 to 5, Monday to Friday. It's a liaison outreach model. And so we've really tried to empower the networks around the young person through collaboration, training of CAMS, youth offending teams. So essentially, a very exciting time that was curtailed by COVID. So just moving on to the next slide. We've got a huge patch that we cover, and prior to COVID, we sort of were traveling all over those 13 boroughs. But essentially when COVID arrived, we had to change our way of working completely. So we moved into remote consulting, which in one sense was quite positive for our team in terms of our productivity increased quite a bit because of that. Could I have the next slide, please? So most of our work is advice and formal consultations. That's probably about 80% of our work. So moving into remote consulting was actually really positive. It cut out all of the traveling. It meant that networks were a lot more accessible. It meant that we were able to bring networks together on a more frequent basis. We were able to really connect a lot more. But in terms of assessment and intervention, that perhaps was a lot more difficult, because if you think at the basis of adolescence, the hardest task you generally have is engagement. And so then to think that engaging face-to-face is very difficult, to then to try and do it over Teams or Zoom did prove quite a challenge. Next slide, please. And so I thought, with my medico-legal hat on, I thought I'd just bring together some of the issues that we experienced in terms of remote consulting. So there were issues practically with different organisations using different formats, and some organisations wouldn't use some formats and others. So that was an issue. There was issues with young people not having Wi-Fi, not having laptops, issues with them not being available and not having anywhere where they could actually have a consultation. There was then issues in terms of consent and ensuring that you know, the network or the young person is fully informed. And so the biggest problem, and I think this is a huge challenge, I think, for psychiatry at this time, was confidentiality. And that wasn't just that the young people couldn't find somewhere where they couldn't be overheard or separate, but it was also thinking about the professionals, that even if we were consulting to networks, there was lots of times where children were in the home or they were being interrupted. So it's been a real challenge in terms of confidentiality. And also in terms of risk assessment, we've found that, you know, people would tend to take a different approach. So it's very much trying to embed that you take the same approach to risk assessment safeguarding as you would if you were having a face-to-face consultation. The next bit that came up quite a lot was recording consultations. So it was so easy, you know, in this, with the technological advances, for young people to record consultations. And so really thinking about a pragmatic approach to this, and thinking more in terms of ensuring that they don't put those consultations on social media, on Facebook, but thinking about lots of the evidence, such as GP studies, where they're saying, you know, patients only remember 20 to 40% of the consultation. For lots of cases, it could actually be seen as positive and therapeutic. So we really took a case-by-case approach to that. And then next slide, please. And then really thinking about documentation. So we're in such difficult times, and the hope would be that the regulator or claims would understand that issues may have been raised, but it really was focusing that we were very clear about what we were able to do in the current circumstances, and also, you know, making sure that everything is documented very clearly, especially considering that team members may go off sick or they may have bereavement. So it really was a time when we really focused on that area. Next slide, please. And so for the whole trust, I think PPE was a big issue. And so I just put up this slide because I was reviewing the GMC guidance, and I think these are very, very difficult decisions. I was very mindful that our trust gave everyone packs that they could keep in their cars, that they keep separately. So there didn't seem to be, in terms of an outpatient community forensic service, the same issues that people experience nationally with shortages and on inpatient wards. But I think I have had instances where I've turned up and there's no PPE. And so it's very much about thinking, you know, that you are, in a sense, doing a cost-benefit analysis, and you are minimizing the risks where you can, and taking a course of action that's least likely to cause harm, perhaps to yourself or to others.
1 minute.
Last slide, I think. So that's it, really. What I'd like to say is there should be one last slide about leadership, I think. So finally, I just wanted to echo what the first speaker had said, which was really about leadership. I'm only part-time in both my roles, so I can't really say that I've been the leader, as it were, but I've found that the kindness and the way that especially my service manager and all the team have coped with the stresses and the changes in the environment has really been admirable, and I've been very proud of the way that we've functioned during this difficult time. Thank you very much.
Thank you very much, Gabriella. Now we have time for questions, and I've been going through the chat box to get some questions. And just a few things, just a comment or two I wanted to make was, one thing that I don't think anyone spoke about was the fatigue. And this is something that I hear a lot from people about, how fatiguing it is to go through the experience of working in COVID times. Kindness I heard a few times, and I can see it in my own work, how kind people have been to each other and considerate is so important, as well as the leadership. Now, the questions, I'm going to just go through the questions as I see them, and for my colleague speakers, there's some specific questions for you. I'll just address the comments, my answers first. I think I could do that. People have asked about the use of D3. So I'd ask you to comment on that, particularly Anil, if you could comment about the use of D3 as a supplement. We're asked about the tribunal, and thanks, Joan, for asking that. And I know that people have talked about technology. I am despairing of the technology, and how many times I have to say, can you hear me? Can you hear me? That was both at the CASC exams and at the tribunals, etc. So I hope others have got better experience than me. The question about whether face-to-face will ever be replaced by technology. I can answer that. I would say no, but I'd be interested to hear what other people will say. We're asked, Anil, for you to give your account of COVID, your personal experience of COVID and what that was like. And Gabriella, I'm asked to ask you about, will you be using this technology in the future when we hope COVID is more distant risk for us? So with that in mind, probably I'll start with maybe Anil. I'll ask you D3, and yes, if you ask D3, and I'll remind you of the next question then.
Yeah, thank you very much. Yes, D3 is regularly used in SLAM. So we got Dr. Fiona Goran, who is the lead at the National Psychosis Unit, and a strong advocate for the use of D3. But if you look at the patients, the patients with any psychiatric problem, I mean, significant percentage of people, significant number of them suffer from D3 deficiency. So, and D3 supplementation is found to be effective if people have a D3 deficiency. And let me get the numbers correct. I think only 14% of people with psychosis have got sufficient D3 levels. And the D3 deficiency patients could be, the risk of acute respiratory infections or severe respiratory infection could be reduced from 60% to 32%. So with a number needed to treat of 8. Yeah.
I think that's a really good takeaway message. Now I want to put two questions together to you about your use of technology, although and how you feel that will be, does it replace face-to-face, and your personal experience of COVID, if you're prepared to share that.
Yeah, I am very, yeah. So, yeah, so the technology, I mean, so as I was saying, really, it's suddenly all these community teams, we are able to connect them in ward rounds, and all the things we have been trying for years, really, you know, sort of it suddenly sort of became much easier to do that, and we had all the support from our IT department and all that. With the tribunals, I mean, I personally, from my office, I had a good experience because I had to observe one of my, I mean, yeah, so if you use Google Chrome, I never had any difficulties, but the ward staff initially had some difficulties, and it has improved as time went. But yeah, so generally, I think over the last few months, the technology has improved. I personally never had difficulty, to be honest. As regards my personal experience, yeah, as I was saying, I sort of, I was about to talk about that and when the phone rang, maybe. So it is difficult to fit in all these slides in 10 minutes. So anyway, so when the sort of the COVID outbreak started, really, and I thought I was rather sort of I wouldn't get it because I'm somebody who doesn't miss. I mean, I've mastered the skill of social isolation over the years in some ways, really. You know, I don't go. I mean, I don't go out that much, really, and also yeah. So but within a week, I had the most sort of severe form of, I mean, from my perspective, of course, of the illness, and I was bedridden for 8 days. So with my oxygen saturation sort of went down. I lost smell, and I recovered it only a few months ago. I mean, a month ago, I would say. And I had it in March. So anyway, so I was bedridden, and my oxygen saturation went down to 92% at one point. And I thought I would ring my sort of medical school mate, who is the lead respiratory physician here in the local hospital, and I rang him and said, oh, my oxygen saturation has gone down. And they could do this telephone assessment, by talking to you. And they said, throw away that pulse oximeter and just get some rest and go back to work after a week, which is what happened, really. I scored well all of a sudden. And after 8 to 9 days, things started getting better, and I didn't need to go into hospital, and I went back to work. And
I think, Anil, just sorry to interrupt you, because I know from the London Division, we've heard stories about people working in mental health who have died as well. So, well, we're glad you're okay.
Yeah, no, of course. I'm not saying that. Many people had quite severe form of the illness, and fortunately for me, I didn't. Also, my managers, the ACD, the clinical director, and senior managers were extremely supportive. Because of the merger of wards, we had the consultant from the other ward working on my ward, and so I didn't have to worry about anything, really. So I just when I got better, I just went back to work, really.
Thank you, Anil. If I may turn to Gabrielle, and the question for you is: will you use this technology in the Gabrielle, will you use this technology in the future?
So basically, our service is quite different in the sense that 3/4 of our work is sort of consultation to networks or advice to individual clinicians. So for that part of the work, it was wonderful. But for face-to-face consultation, all the young people that I was attempting to assess were very unwell or didn't have the communication skills. So it was good for a spot check, but it tended to be that then I had to enlist a face-to-face appointment. And so it's very hard to assess risk over, Zoom in an adolescent that's potentially, at high risk of exploitation or other things. So I would say hybrid. So use the best of it, but don't rely on anything. What's the phrase that I always hear? It's, never marry a hypothesis. So in a sense, be versatile.
And I can see from the chat that we have great fans of technology. And then I have to admit to being a technophobe and feel like throwing the computer out the window at some stages. And we have very limited time. I do thank Dr. Iman from Bangladesh giving a case, and nice to hear people from so far away. I did live in Bangladesh last year, so I have very fond memories of Bangladesh. But anyways, getting back to, I think that we've probably covered most of the questions, and I just wanted to give some reflections from myself, really, about things that I have picked up from working in disasters and like Ebola epidemic and things I've heard from the speakers as well, that I really wanted to emphasize is about self-care, and looking after ourselves is so important. And looking after ourselves also means looking after our colleagues. And with something like this, it can bring out the worst and the best in us. And we can see it in ourselves that when we're overworked and stressed, we know when we're getting the worst out of ourselves. So I think it's a great time for reflection of ourselves. Also by self-care, not only of ourselves and our colleagues and all the staff, including domestic staff as well, who are part of the team. And I must be considered always, as I know sometimes they can be forgotten about. Also, the one thing I've learned from disasters and epidemics and other things is always think of your children and make sure your children are okay. both your children and the children of your patients, because they might be suffering in a way you don't think about. They will be experiencing it in a very different sorts of way. And when schools are being closed, it's a very different world. And I would just, oh yes, the other thing that we bring from the disaster world is the principle of building back better. And I think we've touched on this, that this is a terrible time, but we've actually learned a lot about how we can make things better when this is over and as we move forward. It's about technology, but it's also about the relationships we've made within our teams and with our colleagues, and how we've all kind of come through this together in a very difficult way. And I regret to say that the next few months are predicted to be very, very difficult. I would just put a shout out for all my colleague nurses and OTs and all the other disciplines working so hard. I did some staff support with intensive care nurses during the peak of the epidemic. And I really think, oh my gosh, that was just, it was just, I don't know if heartbreaking is the word, but to see how some of our NHS colleagues work during this terrible period. So please do just thank our colleagues, and I really loved Suhana's biscuits and hand cream gifts and compliments. Maybe that's the takeaway message I want all of us to take away. Compliments and chocolate and biscuits is always a good way to people's emotions or hearts. Well, maybe just me, but. So I have to finish there, and I'm sorry we didn't get to answer all of the questions, and there's been some really interesting chat comments. We'll try and put this into our newsletter at the end of the month, and please do forward any further comments, and we'll try and bring this to the London Division and how we make use of this webinar. So I think that we do need to keep to time, but there's about 1 minute left if anyone wanted to say anything, please.
I just think what you've said about being kind, and when things don't go the way you hope they should go at these difficult times, please have compassion for yourself and your colleagues.
And just remember, I think the other thing is just when we are so stressed ourselves, we make mistakes. And we will make mistakes during this time. We will get irritated with everyone. Remember it, we are all human, but to be kind and nice to everyone. A bit cliche, but with that, I will say thank you, everyone, and thank you for all our attendees from everywhere, including Bangladesh. Thank you very much, and have a good evening. And everyone, be safe, wash your hands, wear a mask, you know the rest. Good night, everyone.
Thank you. Thanks.
Good night.
All right, good night.